Correct answer here is A. And again, even if I didn't remember an example of an alpha glucosidase inhibitor like Precoce or Glycet, they're very unusual. Remember we said that almost all categories of diabetic medications, in addition to hypoglycemia, no different than blood pressure for hypertensive meds, hypotension, the other major side effect was GI upset, excess gas, bloating, things like that. So nausea, anorexia. So that would always be a really good way to generalize some side effects of all anti-diabetic medications. So A is the correct answer. Correct answer here is D. D as in dog. So now we're going to move into the acute consequences of uncontrolled diabetes. We're going to be talking about the two main complications for both type 1 and type 2 diabetes. Type 1 diabetes complication is hyperglycemia that produces diabetic ketoacidosis, and the complication for type 2 diabetes is hyperosmolar hyperglycemic state or hyperosmolar hyperglycemic non-ketotic syndrome. So HHS or HHNK is that complication, and we'll be talking about that more. We'll talk about medication-induced hypoglycemia and what we do for that. Volume depletion and electrolyte abnormalities are going to be a consequence of the hyperglycemia. Because with the hyperglycemia, those large glucose molecules are very hypertonic. Remember that water is going to move from hypo to hypertonic, and so those large glucose molecules pull water towards it, and they end up with having an osmotic diuresis effect. So they're going to have a large amount of volume depletion because of the osmotic diuresis, because of those large glucose molecules being hypertonic. Increased risk of coagulability, we'll talk about if the patient has uncontrolled blood sugar, that increases their platelet aggregation, so increases their platelets sticking together and more likelihood of forming clots. Decreased ability of white blood cells to fight infection. We've talked about this a few times, but once your blood sugar is consistently greater than 200, that's the threshold that basically freezes and disables our white blood cells. It also shortens lifespan of the white blood cells, so that's also a contributing factor. And then thirdly, we know that bacteria love sugar, so it's a medium that really likes bacteria as well and can increase the risk of infection. So it disables the white blood cells, it shortens the lifespan of the white blood cells, and it gives a good medium for that bacteria to feed on the sugar. Impaired healing, most of this we want to be thinking about decreased circulation and the peripheral vascular disease effects or consequences of hyperglycemia. We know that diabetes is the leading cause of non-traumatic amputation as a direct result of impaired healing and impaired circulation. And then more extensive tissue injury with MIs or CVA are documented in the literature as well. So this separates out the macrovascular or large blood vessel complications and the microvascular or the small blood vessel complications. So macrovascular, all of this has to do with the atherosclerotic changes that we have vessels and arteries that become occluded with plaque, and we have higher risk of cardiovascular disease and MIs, cerebrovascular disease such as CVAs and TIAs, and then of course the peripheral vascular disease that results in that decreased tissue perfusion and wounds that won't heal and foot ulcers and potential for amputations of toes and feet and things like that. Microvascular changes, we're looking more at the eye and the kidney problems. So retinopathy is the leading cause of blindness. Diabetes is the leading cause of blindness or because of the retinopathy, and then nephropathy. So patients with diabetes can develop renal disease within 10 years. So if they've been diabetic for a long time, and especially if their diabetes has been poorly managed, they will have the chance of developing chronic kidney disease sooner than somebody who is doing well with their blood sugar control. But again, patients on dialysis, the largest percentage of patients on dialysis are diabetic patients with end-stage renal disease. Neuropathy and nerve damage, we know that many diabetic patients have neuropathies where they have that pain, tingling, a numbness in their feet. Can extend all the way down their leg, but initially it starts kind of in their feet and then works its way up as it gets worse, as there's more nerve damage. You have probably seen non-opioid analgesics prescribed for this, and then in particular a lot of gabapentin or Neurontin that you will see prescribed for diabetic neuropathy. A few things that we certainly want to educate our patients about related to the neuropathy is just that loss of sensation and the higher chance of injury or developing sores in open areas that we can't even feel and know that they're there. So we'll be talking about the foot care rules and principles of all of the things that we want to do to take care of their skin and feet, and to really look and assess their feet daily. So they can get real dry skin, it can become calloused, and of course it can break open more easily. You need to make sure that you're looking between the toes of our diabetics, making sure that we're checking every single area of their body and skin for open areas, and especially on the lower extremities where they have that neuropathy and can't feel as much. Peripheral vascular disease, we talked about that being a direct result of the decreased blood supply. That chronic atherosclerosis that's narrowed the vessels that results in that decreased blood flow. Again, with decreased blood flow, we think of decreased oxygen and nutrients getting to tissues and cells, therefore poor wound healing, and they can develop those diabetic ulcers and gangrene. They can have necrosis and end up with needing amputations. As far as immunocompromised, we always want to be mindful of who our diabetic patients are. They are going to be higher risk of infection, and because they have that suppression of the white blood cells. And again, remember that if they have hyperglycemia that is greater than 200, that impairs the ability of those leukocytes to work. It basically disables them and freezes them. And so, while we may have good white blood cells in our body, we don't have ones that are able to work for us. And then it also decreases the lifespan of the white blood cell. And remember, bacteria loves sugar, so that increased risk for that reason too. The foot care principles are here, so this is very, very important that we understand what it all means so that we can properly educate our patients. We do talk to them about making sure that they're checking water temperature with either a thermometer, there's lots of devices that help with that, or their elbow, so that they make sure that they can not have too hot of water or too hot of temperature for showering and bathing. We want to make sure that they're drying off all areas very well, especially between their toes. They may be applying lotion, and that's good because they do have dry skin, but we want to make sure that they're not caking it up between their toes, because then all of that lotion and moisture is sitting there and can cause a wet area for bacteria and yeast to grow. As far as toenail care, we know that we need to make sure we're trimming them straight across. They really do, if they're diabetic, recommend a professional podiatrist. They usually have the very thick nails that you wouldn't be able to clip with a normal clippers anyway, and all that thick nail is showing you that chronic decreased tissue perfusion and chronic peripheral vascular disease. As far as shoes, they should always wear a shoe that has a closed toe so that they're not bumping and not feeling it. That's just more protective for their feet. They shouldn't be walking bare feet. They should be using a moisture wicking cotton sock so that they don't retain a lot of moisture there. And then the last bullet talks about, getting in good habit practices of not crossing the legs, certainly reducing anything that would cause vasoconstriction like smoking, stopping smoking, and then increasing blood flow to the feet by elevating, wiggling toes, and just doing some of those range of motion activities is good also. This is an example of what could be like a handout that we could give our patients that highlights some of the key areas with little pictures. I think it's a really good depiction of what we can find out there. There's a lot of good information for patients now. We just have to find it for them and get that printed for them. So now we will compare and contrast diabetic ketoacidosis and hyperglycemic hyperosmolar non-ketonic syndrome. So again, DKA is the acute complication of type 1 diabetes, and HHNS or HHNK is the type 2 diabetic complication. So when we look at these side by side, it basically depicts, which one is type 1 and which one is type 2. We look at DKA and it's more of a sudden onset, whereas HHNS is more of a gradual onset. They typically have many of the same causes. Again, we don't always know why they're going to go into a hyperglycemic complication, but a lot of the times infection, illness, or missed doses of insulin for those that are type 1 or undiagnosed diabetes is a common reason. They don't know they have diabetes until they end up with a complication of ketoacidosis, and then they get their diagnosis of type 1 diabetes. So there's some sort of stressor or something that's increased their blood sugar initially. That usually is the case with developing these complications. I want to point out the last bullet on each column, which is really important, and you can see that they have all the same clinical features except type 1 diabetes complication of ketoacidosis will have acidosis, and it has it right in its name, whereas type 2 complication has no acidosis. Both of these complications result in hyperglycemia. Both will result in having the patient to become a lot of volume depletion via osmotic diuresis, so they become dehydrated and have a lot of electrolyte losses associated with that volume loss. And then type 1 will develop acidosis, and type 2 will not have acidosis. And we'll talk more about why, the difference on the acidosis here in just a second. So if we start by looking at DKA, diabetic ketoacidosis, they end up with severe dehydration and electrolyte loss. Because of the hyperglycemia, remember those large glucose molecules are hypertonic and draw water to them, and then we have this large amount of diuresis after that. So polyuria and dehydration, electrolyte loss along with it is a huge initial problem. With that, if you look at the signs and symptoms listed in that first column under DKA, you'll also notice low blood pressure, obviously with low volume, tachycardia as that initial compensatory mechanism for loss of volume or hypovolemia, weight loss, dry skin, lethargy, basically all the signs and symptoms of dehydration or hypovolemia. You see that they will also be dehydrated with HHNS. They'll have the same signs and symptoms. It's just the main difference is the acidosis again that we'll be getting to. Glucose, you'll see, is elevated in both. Typically, when somebody comes with DKA, because they are breaking down fatty acids, which is the ketones, and they'll have ketones as a result of that fatty acid breakdown, they will become very sick. They'll have nausea, vomiting because of the acidosis. So they'll usually present to the emergency department sooner, which is why they typically have a lower blood sugar than somebody with HHNS. I mean, they both have hyperglycemia, but you can see greater than 300 for DKA, greater than 800 for HHNS. We can see patients with a really high blood sugar with the HHNS because unfortunately they don't have the feeling of sickness and the GI symptoms like they do when they're in acidosis, and so they don't go to the doctor as quickly and they delay treatment. So their dehydration can be even more severe than somebody with DKA because of the delayed onset of getting help and seeking a doctor, and their glucose can also be elevated because of that reason as well. You'll notice the next difference is for DKA, they will have positive serum and urine ketones. Now ketones, positive ketones, as we learned, we do not want glucose, ketones, or protein in the urine. We said that that was normal to not see those in the urine. So when we test positive for ketones in the urine or the blood, that tells us that the body is breaking down stored fat for energy. So because there is a lack of insulin, the cells are starving, and so it's going to start to break down the body's fat and stores for energy, which then will result in positive ketones. Those positive ketones, those ketones are acidic, and so the ketones causes that acidosis, so metabolic acidosis. if you see the ABGs, you should also, just a good time to review, do I remember what metabolic acidosis looks like as far as numbers? So of course the pH is less than 7.35, but remember metabolic equal. So the HCO3 will also be down. So pH down, HCO3 down, which produces our metabolic acidosis. Now you see the CO2 being down also, and that is just showing compensation. So as soon as we have acidosis, remember our lungs are going to try to blow off some of that CO2 and to try to get rid of some of that acid. And so that's where you will see those Kussmaul's respirations listed there. And that's that deep, rapid respiratory rate trying to blow off CO2. Now, if we go over to the right and finish up on HHNS, you will see that they are negative for ketones. So they do not have an absolute deficiency of insulin, right? With type 2 diabetes, we have insulin, we just don't usually have enough of it. So they are hyperglycemic, but they don't have enough insulin or don't have good insulin receptor site sensitivity, and so their blood sugar continues to increase, but they do not ever break down our body fat for that stored energy. So they will never have acidosis, so no acidosis and no ketones in the blood or in the urine. That's the main difference between the two. This slide is just reviewing what we just talked about as far as metabolic acidosis, reminding you of the numbers and reminding you of the compensation part for CO2. I really like this flow diagram, how it shows all of the physiology of what's going on. Right down the middle, it talks about the hyperglycemia and how those large glucose molecules result in the osmotic diuresis because of that hypertonic pulling effect. So water and electrolyte loss, you will have sodium and potassium deficits. That hypokalemia is really significant initially, as well as the dehydration and the hypovolemia. So going off to the right there under dehydration, we look at the decreased perfusion and therefore decreased excretion of H ions, which in addition to the dehydration itself contributes to the metabolic acidosis. On the left side, as soon as we have lipolysis, which is breakdown of fat, that's where we have the positive ketones. Ketones is fat breakdown, and so we have ketonemia, which is ketones in the blood, and ketonuria, which is ketone in the urine. So those ketones are acidic, and so we will develop that metabolic acidosis. And that metabolic acidosis will result in that acetone breath or that fruity odor. It will also be the reason for the Kussmaul's respiration or that deep rapid respiratory rate, because that is the compensation that is trying to occur with blowing off CO2. This is a really good Creative Memories notebooks, but I do want to point out bottom left where it says hyperkalemia. This is only really very briefly initially because of the concentration of the hypovolemia, but we are more concerned about hypokalemia with the polyuria. So by the time that they come in, they have hypokalemia. But I guess if we were to catch them very, very early, there is a chance that they have hyperkalemia because of the concentration part, the hemoconcentration with the volume loss. This diagram is also in your textbook. It's just another good way to look at how things all work. This one is looking at HH and K, so you're going to see the same things as far as the dehydration, the hypokalemia, but you're going to see that there isn't the breakdown of fat or too little to actually show to develop acidosis. So basically the main difference between DKA and HHNS is just no acidosis with HHNS. Treatment of DKA and HHNS, the goals of treatment, if we think about the priority problems, we think of the hypovolemia, we understand that rehydration is going to be really important. We think of the hypokalemia and the importance of restoring the electrolytes. We think of the hyperglycemia, obviously very important to lower that blood glucose. And then for type 1 or the DKA, we think about acidosis and needing to reverse acidosis. So rehydration, restore electrolytes, lower that blood sugar, and then if it's DKA, also reverse the acidosis. So try not to make it too complicated. Just try to think about what's going on and how can we reverse these problems. So a fluid replacement will typically be an isotonic solution, 0.9% sodium chloride, and they will need initial fluid flushes for that hypovolemia to reestablish tissue perfusion and reestablish blood flow to the kidney. And also that fluid flush will enhance excretion of glucose in the urine to kind of try to help with lowering blood sugar that way too. Nursing interventions with the fluid replacement, of course, checking electrolytes every hour, acrid INO every hour, and with any fluid flushing, we're always watching for fluid volume excess. Now the fluid will change and dextrose will be added to the fluid solution once we achieve a blood sugar that reaches 250 to 300, and this is clearly delineated on your unit protocols for DKA. But we have to add dextrose, and you might say, well, why are we adding dextrose when their sugars are high? But as we're bringing down their sugars with insulin, we need to they still need insulin, so we have to add dextrose to prevent hypoglycemia from the insulin administration. So it's basically helping to counteract hypoglycemia because of the insulin. Correct electrolyte imbalances, again, K may be elevated in only very quickly and initially due to dehydration, but mainly we're watching for hypokalemia, and we're watching for dilutional hypokalemia after we've done the rehydration, plus hypokalemia from all of that they have excreted as far as that massive polyuria. We also will talk about how we can adjust the potassium as far as adding it to the fluid. Again, we're only adding it to the fluid once we know urine output is normal, but that is something that they could do as they're monitoring it. Basically, they're really watching that potassium closely every hour along with the output. They're on a cardiac monitor, watching for hyperkalemia, tall peak T waves, and watching for those EKG changes of hypokalemia, which would be the inverted T or the U wave. Insulin bolus, of course, is a high priority. They have hyperglycemia. They need insulin. So they'll be initially get a bolus, and then they'll be on a continuous IV infusion. So this insulin bolus initially is going to be IV push, and then the IV continuous will be hung right after you do that IV push. So this will replace insulin slowly. We don't want to decrease the blood sugar more than 100 per hour, so because that can cause cerebral edema. As glucose moves from the blood to the cell, it takes water with it, so that's why we have to do it very slowly, typically not decreasing it more than 100 per hour. Again, for nursing interventions, we're monitoring the glucose hourly, we're monitoring ketones, and watching for any signs of increased intracranial pressure or cerebral edema that may indicate we are lowering the blood sugar too quickly. Most facilities will have a dual sign-off for insulin, for IV insulin. Not all facilities have a dual sign-off for sub-Q insulin, but they will definitely have that dual sign-off and dosage calculation safety for IV insulin. So I really liked this diabetic sick day rules picture. Just even the color coding and some of these things can be helpful for patients or even help you as a learner to remember. But prevent dehydration. Oh, I see dehydration spelled wrong, but other than that, fluids, juices every hour. Continue feeding. Add small complex carbohydrates. We don't want to add high sugar necessarily, but we do want some small complex carbs. Treat the nausea, treat diarrhea, treat fevers, treat anything like that could be contributing to dehydration. Rest is so super important. Of course, the blood sugar monitoring should be more frequently. They should be doing it every 2 to 4 hours, 3 to 4 hours, sort of depends their baseline and what they're running. Checking ketones, and again, if they're type 1 diabetic, they will definitely also be wanting to check their ketones every 2 to 4 hours or every 3 to 4 hours. Giving the scheduled insulin, not holding the insulin just because they're sick and not eating. So that's a mistake that sometimes people make initially, and that is not what we want them to do. In fact, extra insulin is typically needed when they are ill or having an infection or having a stress response. And then just knowing when to call the doctor. Diabetic patients need to take it very seriously, and on the next slide we will go through when they should call their doctor. So when to call the doctor, we should review this with our patients very thoroughly. Vomiting, unable to keep fluids down, liquids or diabetic pills. You know, any illness that's lasting greater than 1 to 2 days, especially if it includes vomiting, diarrhea, and other things that they're not able to, that they're losing a lot of volume and or unable to keep their medications down. Blood sugars running greater than 240 typically for more than a day. If they've had a couple extra doses of insulin or supplemental correction and they're still not managing, is, you know, that is significant, and a type 1 diabetic is probably going to need hospitalization for that. And even a type 2 diabetic certainly may need hospitalization, but they for sure need to let their doctor know if they should come in for evaluation. Temperature greater than 101 for 24 hours. Certainly if the type 1 diabetic is testing their ketones at home and they have ketones, moderate or large ketones, that tells us that they're burning fat and stored glycogen is being used up, and they're breaking down their own fat for energy, which means they're not getting adequate insulin or not having utilization of that insulin. And then kind of the opposite of all of the hyperglycemia stuff would be more than 2 episodes of unexplained hypoglycemia. So again, if they're having episodes of hypoglycemia, that's just as critical, because that can be just as fatal, especially if they go hypoglycemic and unresponsive and unaware of what's going on and not able to seek help at that time. I really, really like this SICK acronym, sugar, insulin, carbs, ketones. Again, a really good way to remember the priorities of what we should be assessing, what we should be instructing our patients to do and assess at home as well. So the dosage calculation that could be applicable related to diabetes care would be a continuous insulin infusion. This would be an example of how the order is written. The insulin will come in a bag, 100 units of regular insulin and 500 mils of saline. So that will be the initial concentration. That is very standard, but obviously the units per hour will be ordered by the doctor, in this case 5 units per hour. So I would like you to be able to calculate that. You can do that on your own now, and then on the next slide we'll have the answer for you. Here is the answer for that dosage calc. If you're still struggling with how to set that up and what that looks like, then you'll just need to get help on that. This is another really nice slide on hyperglycemia symptoms. We think of the 3 Ps, polyuria, polyphagia, and polydipsia. And then there are some other ones, the fatigue, change in vision, blurred visions, of course, sores that won't heal, infections and things that are more frequent, numbness or tingling of the hands and feet. So again, just a nice visual for you that we can also use in education as well. I think it's important to be able to look at hyperglycemia and hypoglycemia side by side. It's just notorious, it's just always easy for students and even nurses to get mixed up the difference between hyper and hypoglycemia. So I need you just to take some diligence in learning these and looking at them side by side to see the differences. So they are quite different, and so you want to be able to know which is which, be able to recognize it. Of course, if you see any signs and symptoms that could be either hypo or hyperglycemia, your first action is going to definitely be to check a blood sugar and go from there. And then just to remember that we do have standing protocols for treatment of hyperglycemia and hypoglycemia. Typically that standing protocol for hypoglycemia starts at less than 70 and or symptomatic. So again, we need to know pretty readily, how to correct a hypoglycemia, quickly without having to look up things. Just another one of the creative memory notebooks for remembering hypo versus hyper. Now again, we just talked about hyperglycemia treatment in talking about treatment of DKA and HHNS. If somebody's hyperglycemic, their main treatments are going to be insulin, hydration, fluid and electrolyte replacement. And for hypoglycemia, of course, we talked about them needing glucose, so either carbohydrates that they can actually ingest. So if we have hypoglycemia in a conscious patient that can swallow, well then we'll give them 15 grams and recheck in 15 minutes. If we have somebody that is unconscious and hypoglycemic and does not have an IV, they will get glucagon. If they are hypoglycemic and unconscious with an IV, then certainly they would get dextrose 50%. And even if they're hypoglycemic with an IV, but are really at that border where they can't really, we're not sure if they can swallow, well then we would go with the IV 1 amp of dextrose 50%. So again, 15-15 rule if they're awake and we can get them to do that. Otherwise, it's going to be glucagon or dextrose 50% through the IV. So this is sort of just review, but it's just I want to clarify and re-emphasize that we don't want to assume that any diabetic patient has knowledge. Even if they've had diabetes for years, we still want to do our assessments and teaching very thoroughly and diligently. So we definitely want to do some questioning about any symptoms, what's kind of their blood sugar been running, or have they been adhering to their regimen, such as checking their blood sugar as often as the doctor wants them, following their diet that they're supposed to, and or taking their medications as prescribed. Again, where are they at with management of their chronic complications? Do they already started to develop some of those complications, or what's that look like? As far as physical examination, blood pressure we know is important, their body mass index and their weight is important, and then just the foot and skin examinations. Lab tests, they'll do that hemoglobin A1C. They typically will want to do that quarterly and see how their blood sugars are being managed over time. And then a fasting lipid profile for sure once or twice a year, they'll check that. And then they typically will do a urinalysis also once or twice a year for protein, ketones, glucose, and just looking for that as well. Needs for referrals, we know that they should be seeing an ophthalmologist. They should be having a very thorough eye check with their risk of diabetic retinopathy. Podiatrist, of course, for the good foot care that we know we want them to have, and nail care, dietitian and diabetes educator that can definitely help with all of the reinforcement of education, carb counting, healthy diet, exercise, weight loss, and all of those things that we know are so very important in the management of diabetes.